Alrighty, let's begin. Any questions on stuff from last time? Everyone ready to go straight to 428, 29 maybe? Just kidding. I will probably finish up this section, and then on, I think, Tuesday, when we have our next class at 8, we'll do surgery then, and then we'll have the review after that. So just a scant 43 slides today. I think we can get through that in probably 3-4 hours. Okay. Anywho, so finishing up on a couple of drugs, again, that are pretty nasty from a kidney standpoint that we want to be careful with. That one's going to be Amphotericin B. Now, again, not something you're going to use super commonly unless you're working like in the medical ICU or somewhere you're dealing with more like immunocompromised patients or anyone who's having some pretty nasty invasive sort of fungal infections. This is a very good drug for that. However, it's very bad on the kidneys and several other organs. And so you can find that, anywhere between 30 to 80% of patients end up developing some degree of nephrotoxicity. So it's almost a certainty with this drug. And that's why it's we are so cautious when we decide to use this, because we know there's going to be some side effects associated with it. What you end up having is a lot of damage done to those cells within the proximal convoluted tubule. So you end up having a lot of electrolyte wasting, potassium, magnesium, some sodium that can happen there. And so you find this tends to be dose related, so it can depend on just how big a dose you need, depending on how severe the infection is. If it's in the CNS, you probably need to run higher doses, and that could be more likely to see damage done there. And so there's some ways we can try to get around that. So for instance, I've probably mentioned this before, but here's a liposomal form of amphotericin B called ambisome. And basically what they do is they have this kind of lipid bilayer that's kind of been impregnated with molecules of the drug. And so by doing that, it tends to lessen the toxicity on those cells. Also, what do you think it increases? The cost of the medication is way more expensive to get kind of specialty sort of dosage forms like this. But again, if it can help the patient, it's going to be good overall. If you don't have to put them on rounds of dialysis and do some permanent damage to the kidneys, it tends to be a good cost benefit sort of analysis there. If you ever get to see Amphotericin B, it looks like orange juice or like Tang in the IV bags. It's kind of interesting looking. I like things that have different odd colors and whatnot. But that's a good one. So anyway, some risk factors. Certainly, if they have pre-existing kidney disease, this is going to make them even more likely to develop damage being done here. And then volume depletion is another big one, because we know you're going to end up losing a lot of fluids and electrolytes with this one. So by keeping them tanked up and keeping them well hydrated, that can really help to mitigate a lot of those issues. And then also discontinuing other concurrent nephrotoxins if you can, right? But in some cases, you can't get around it. If they have nasty gram-negative infection, you may need some aminoglycosides, and then they develop a fungal infection on top of that. You can see how you might have to use both in those cases there. So anyways, we mentioned, liposomal forms can be very useful, but much more expensive than the conventional sort of amphotericin B, which is relatively cheap for the most part. And again, as far as treatment goes, mainly it's just supportive. You try to get them off the drug as soon as you can, and then try to replace electrolytes as needed for them. Okay, and then talking about the intratubular obstruction here, that's usually where the drug crystals will precipitate out in the actual renal tubule. That can happen there. So certainly you can have the obstruction. They can develop into a nephritis and can have this like acute tubular necrosis kind of superimposed on top of that. So it can kind of be multifactorial in those cases there. There's a couple of drugs we can mention that do that, but mainly the big ones you're going to see are going to be things like acyclovir can be particularly bad about that. Methotrexate tends to be pretty bad as well. But some other things you can see where you have kind of precipitation of other metabolic byproducts can be things like tumor lysis syndrome, which you mentioned you see in cancer treatment, especially leukemias. We can do things like trying to prevent this by doing adequate hydration and giving allopurinol. Remember how allopurinol worked? Used it for gout. It worked for gout because it prevents formation of uric acid, right? Because again, when you're metabolizing those purines are being broken out due to that DNA all leaking out, you can try to mitigate that by giving allopurinol. It's a xanthine oxidase inhibitor, and that helps to prevent that production of uric acid. So that is one useful thing we can do. We also mentioned you can do that raspuricase, which actually directly breaks down uric acid that's already been produced there. The other big one you can think about is things like rhabdomyolysis. So the one thing you kind of commonly think of is like with statins, where if you were to have, say, like a 3A4 inhibitor on board, statin levels are going up, they end up developing rhabdo from this. And so you can see that myoglobin start to precipitate out. Certainly you can see this with other things, especially if you're dealing with like malignant hyperthermia, which we'll talk more about with the surgery stuff in the next section. But remember what drug we talked about already that can cause malignant hyperthermia? Yep, succinylcholine is a big one. Did you guys talk about that in surgery already? Yeah, what other drugs do that? Yeah, halogenic hydrocarbons with the inhaled anesthetics, essentially. Yeah, so that would be the other big group we'll talk about there. You know the antidote for that? Dantrolene, yes, dantrolene. Dantrolene is a brand name. You might say like Ranadex would be another brand name, but dantrolene is a drug we use for that. But anyway, when you have all that really severe muscle contraction, you see that muscle breakdown, rhabdomyolysis can form that can cause an intratubular obstruction. And some of that can be reversible. Sometimes it may not be, depending on the cases. We see in the tox world with like illicit substances, with a lot of like designer amphetamines and things like that. Certainly, there's been some cases like bath salts and some other like flakka and different things like that, where they were severely hyperthermic that led to some muscle breakdown and rhabdomyolysis. So it was not uncommon to see case reports where patients would have to go on dialysis after this, even after a single dose of some of these designer amphetamines. But anyway, some of the things that are going to help to promote that precipitation are going to be things like low urine volumes. They have a low drug solubility, which can be affected greatly by pH. Remember our Henderson-Hasselbalch equation, all that? Remember? Hopefully no one's repressed those memories completely, but remember going back that like dissolves like, right? So again, if you can have something like methotrexate, it likes to be dissolved in bases. It's a weak base itself. So by alkalizing the urine, you help to keep it in solutions. You know, for that particular drug, that's one way we can do that. And we mentioned acyclovir tends to crystallize out. This is probably going to be one of the more common ones you're going to run into, especially for treatment, especially IV treatment. You're going to see this more often, definitely methotrexate, if you deal with like cancer patients on a regular basis. And what's not going forward? Okay, so any questions on drug-induced kidney injury? All right, so we're going to finish up with some disorders of sodium homeostasis. So mainly we're going to talk about hyponatremia and hypernatremia. We've already talked about some electrolyte disorders before. We talked about like hyperkalemia. Like how do we treat that? Insulin glucose, Kxalate, albuterol, sodium bicarb. Dialysis, another big one, right? Yeah, so again, kind of know how we can manage that. We're going to talk about both hypo and hypernatremia, just because this is one of those areas where, one, you do see it in Florida with some regularity, especially during the summertime. I'll never forget this one lady came in with hyponatremia. You know, she was, say, late 40s-ish in absolutely no kind of athletic shape. Decided to go to boot camp in the middle of the summer, did not stay very hydrated, was just sweating buckets, and then got very hyponatremic and ended up developing seizures, and I landed her in the ICU. So that's not an uncommon story you're going to run into, especially being here in Florida. So it's important to cover this, because this is another one of those things where if you treat hyponatremia inappropriately, you can absolutely kill somebody. If you are giving someone, trying to manage hypernatremia, you can absolutely kill somebody potentially by screwing things up. We'll talk about how to do that in a little bit, not to scare you, but just so you can have a healthy respect for the disorders and the drugs we use to treat them. So typically, when you're dealing with salt and water, total body water is going to be making up basically 60% of it is going to be intracellular compartment, right? So it's going to be mainly maintained by things like a lot of potassium within the cells, a lot of phosphates within the cells. The extracellular compartment, around 40% of that total body water, is going to be mainly held in place by things like sodium, chloride, and bicarbonate, right? That kind of makes sense. If you think about your cells, I like to think of them as salt-wrapped bananas. We're basically going to have a lot of salt on the outside, a lot of potassium on the inside, right? Still that analogy does not seem to resonate with you at all. So I'm going to continue using it. There's going to be one class that will appreciate that. Anywho, but how do we maintain that balance? Sodium potassium pump, right? So again, we need that sodium potassium ATPase pump to keep things in check, essentially. What you're going to find though is that the osmolality between the intracellular and the extracellular fluid should be maintained in pretty good balance, because otherwise, what would you see happen if it was out of balance? Where would water shift to? The place with more osmolarity, a place with low osmolarity? Yeah, a place with high osmolarity, right? So again, water's going to want to go to dilute things out. It's going to go, things like to go from areas of high concentration to low concentration. Water's going to be flowing through those membranes to try to dilute out areas of higher osmolarity. And we can actually modify this. We can do things like shift fluids around by giving different osmolarity-based fluids, right? So we can give things like hypertonic saline that has a very high osmolarity, or mannitol, which has a high osmolarity, to draw fluid out of the CNS. Like if you have intracranial hypertension, if you're having cerebral edema developing, you can draw fluid out of the brain by doing that. And so we can manage that, and this is why we want to look at the different fluids we can give and how to manage that balance there. Because again, usually the biologic membranes are going to be relatively impermeable to things like salt and potassium unless the actual channels are open, versus water, which can flow pretty freely for the most part. So typically when you give things like isotonic fluids like 0.9% sodium chloride, which we mentioned is typically has a concentration of sodium of 154 milliequivalents per liter. Chloride is also 154, right? Because the sodium chloride it's 1-to-1 ratio there. So the osmolarity of that solution is roughly 308, right? Which is roughly isotonic to our fluids in the intravascular space. So when you give a liter of normal saline, where does it like to shift to? You're right, it doesn't shift anywhere. It stays right there in the intravascular space, which is why we like to use it for rehydration. If we know they're intravascularly depleted due to vomiting, diarrhea, etc., we can give them a liter of normal saline, and I'm relatively well assured that the majority of it stays right there in the intravascular space, which is good. That's where I want it to be in those cases. So you should see no net shift of intracellular fluid or extracellular fluid in those cases, right? Now, if I were to give, say, a hypertonic saline solution, something that's going to be hyperosmolar compared to what our natural tonicity is, and that would be anything greater than 0.9% sodium chloride, you're going to see a decrease in the intracellular fluid and an increase in the ECF, right? And that makes sense because as we're increasing the osmolarity there, water is going to be drawn to areas of high osmolarity to try to dilute that out. Okay, so if you had, say, a case where you're very edematous, potentially, or like, for instance, you have extra fluid on the CNS, you can pull that out by giving hypertonic solutions, right? On the opposite hand, if you were to give a hypotonic solution, something like 0.45% sodium chloride or half normal saline, this has the opposite effect. Typically, you're going to see more of the intracellular fluid tend to swell, while the extracellular fluid would tend to shrink overall. Okay, so everyone's with me so far? All right. So anyway, to look at several different types of fluids, we can compare the tonicity. We can look at where the fluid's going to be going when you administer these fluids to these patients. So looking at something like D5W, which is what? Yeah, so it's 5% dextrose in water, right? So again, it's going to be, it's not D50, right? Because D50 is something different. It's what we give for hypoglycemia. But this is D5W, so much less concentrated variety. Notice here, there's no sodium, there's no chloride, and typically it's going to be roughly hypotonic. And so if you had to guess where all the extra fluid is going to be going, you're going to say, well, it's probably going to go more into, what ends up happening actually is that it tends to separate out between the extracellular fluid and the intracellular fluid. The majority of it ends up going more towards the intracellular fluid, so about 60-40 kind of split there. But we call this as free water. You know what I mean when I say free water? Basically, it means that dextrose gets metabolized pretty quickly or gets shuttled into the cells. And so what you end up finding is that not a lot of that fluid stays right there within the intravascular space. That water is going to be basically partitioning out of there and going into the cells or the extracellular fluid, wherever it happens to go. But not a lot of it stays right there within the intravascular space. So D5W is not very good for rehydration because there's really no kind of isotonic or no colloidal pressure associated with that fluid. So that's not great for a volume replenishment sort of standpoint. It's good if they're hypoglycemic, you can give them some dextrose, right? It'll fix that, but it's not really going to fix their volume issues. Now, if I were to give, say, half normal saline, again, this is only going to be about 77 milliequivalents per liter of sodium, 77 milliequivalents per liter of chloride there, and it's going to be hypotonic still, because again, it's only going to be about 154 milliequivalents total here. You're going to find that most of the water is going to be going more towards the extracellular fluid, a little bit to the ICF here, but this is going to be roughly, half of it is going to be basically free water, where half of it should probably stay in the intravascular space. The other half is going to be partitioning out into the tissues. Okay. Versus with normal saline, you're going to find this is isotonic, so there's really no good fluid shift here. All of this ends up staying in the extracellular fluid. Similarly, we see with lactated ringers, where do we use lactated ringers a lot? In surgery, right? So we'll talk about why that is a little later. But basically, this is why we're going to end up seeing. And again, there's several salts are involved in lactated ringers, like magnesium, some calcium, all sorts of things. And again, majority of this stays in the extracellular fluid as well here, as you'll see. Again, no free water because it is isotonic. And then on the other hand, we have 3% sodium chloride. Notice here, this is much more concentrated. Right, so about 513 milliequivalents per liter of sodium, 513 of chloride. Total, it's going to be 1,026, and so that's going to be roughly 3 times what our normal osmolarity is, and so that's going to have negative free water associated with it because it's actually going to draw water out of the intracellular space and into the intravascular space, and then you can eventually pee it out, right? All that extra fluid's got to go somewhere, so typically it just goes out through the urine, and that's why it's good for edematous conditions, things like cerebral edema. You can pull that water out by using hypertonic saline and then just pee off the extra fluid. Okay. So anyway. So normal normally serum sodium is pretty tightly regulated for the most part, because this is the main thing that's going to be determining our plasma osmolality and then also blood volume. Okay, and so we're going to talk about different ways we can regulate this, but the main organ that's responsible is going to be for the kidneys, and so they kind of manage, especially through the hypothalamic feedback, like, okay, well, how much salt and water do I need to retain here? How much can I excrete out? And things that can help with that are going to, what kind of hormones help out with this process? Yeah, ADH is a big one, right? So ADH would cause us to, like, say, hold on to more salt and water. Aldosterone would similarly hold on to more salt and water. So those are going to be the primary things that kind of help us to regulate that in a lot of ways. You can also find the osmolality will actually be affected by glucose and BUN as well. So if you were to do like a calculated serum osmolality, you'd find that BUN and glucose are the other two big things that actually get calculated in that. When we do those for like certain toxic alcohol ingestions and stuff, we'll do those calculations. But beyond our scope here, but just know that those also contribute to the tonicity there. But the main thing we're going to be focusing on here is going to be sodium. So looking at AVP, arginine vasopressin, otherwise known as ADH, so again, several names. Typically when you're giving it as, say, like a vasopressor, or if we're giving it for certain other conditions, you'll see it called arginine vasopressin or AVP. But again, we know it's ADH. We know it's the same hormone, it's just a different name for the same thing. And again, gets released from the pituitary in response to increased osmolarity. Because if the blood has an increased osmolarity, what is that telling us? Too much salt, not enough volume to dilute it, right? So again, ADH gets released in response to that, and what's that going to do to our volume status? Going to hold on to more volume, so you're going to hold on to more water, and what does that do to your osmolarity? Should dilute it, and it goes down, right? So then once you have that lesser osmolarity there, then your brain's going to think, okay, well, we have enough fluid around, I don't need to release as much ADH, right? And ADH not only affects the kidneys, but what else does it normally cause? Well, if it affects blood pressure, what else does it stimulate the patient to do, like a behavioral? Yeah, it makes them want to drink, right? Water, that is, not anything else. But typically water, they're going to be wanting to drink a lot of that, because again, that's going to help to increase blood volume, and that's going to help to dilute out that osmolarity that the pituitary is sensing there. And again, they're going to be binding to vasopressin receptors on the renal tubules. This is important because we're going to see there's certain drugs that can affect this, and we're going to see there's certain disease states that can affect this as well. Have you covered anything about like SIADH or diabetes insipidus, Dr. O, yet? Okay, so we'll talk about that briefly here and the management of that. And when those interact with that, you're going to find the aquaporin channels get put into the luminal surface of the renal tubular cells, and that will stimulate that water reabsorption, and then that thirst is the other big thing we're seeing stimulated there. And then also you're going to see the renin-angiotensin aldosterone system is going to be working in concert with this. It's going to help to decrease that circulating volume and help to decrease the pressure. I'm sorry, when you have decreased pressure, that's what senses that, and that also will stimulate that renin-angiotensin system. And aldosterone is a big thing that's going to help to retain more salt water as well. Okay, so when you're dealing with someone who has hyponatremia, and typically a serum sodium, a normal one is what? Yeah, 135 to 145 is generally considered a normal serum sodium. You may find different labs will report different normals, but that's typically what you're going to see in most instances. And what you can actually do, and I'm not going to get fully on the diagnosis bandwagon, because again, you guys cover that elsewhere, but some of the things we were doing when we were evaluating these patients is to not only look at the salt levels, but we're also going to be looking at the osmolarity of the blood as well, because that can tell us several things. Because we want to find out, well, is it an issue like, do we have a total body salt depletion, or is it a factor of the volume is diluting out the salt that we already have there, right? And so there's different pathophysiologies for each of those things. So for instance, you can have certain things like a normal osmolarity here. You can have the pseudo hyponatremia that can develop. Sometimes you may find that you can actually have an elevated osmolarity with a hypotonic or hyponatremic looking picture, and a lot of that can be caused by hyperglycemia. Do you know any cases where you might see this? Because you mentioned glucose can contribute to the osmolarity. So what cases would you find like really high glucose? Yeah, so like DKA, you may see this, but also in like HHS for type 2 diabetic patients. Those would be other cases where you'd see very high blood glucoses, and that would actually cause a hyperosmolarity of the blood, but the serum sodium may actually get diluted out, and so you may actually find the serum sodium is low in those cases. So that would be one thing there. And typically low osmolarity, we have to then decide, okay, well, is the patient euvolemic, hypervolemic, or hypovolemic? What are some ways you can tell a patient's hypervolemic? Like a physical exam. Edema is a big one, right? JVD, lung tunnel junkie, little things like that. And the hypovolemia, how did you tell? Look pale. Tachycardia is a good one. Yeah, we look for tachycardia quite frequently. Skin turgors decrease, things like that, right? So again, you're going to be evaluating your patient to decide, okay, what's their volume status when you have someone has a low serum osmolarity with a low sodium. I'm trying to figure out, okay, well, what's going on here? Because this is another place we're going to try to figure out, okay, well, what's the issue here? If they're hypovolemic, this is going to be managed differently than if you were to say have hypervolemic patient versus if they're euvolemic. Okay, typically when we're going to see a euvolemic patient, this is where we're going to be focusing on things like SIDH. But we'll get into more detail on these in just a little bit. But just know this is kind of the thought process, is the algorithm you kind of go through when you're managing a patient who has a low serum sodium. The next thing is to figure out what the osmolarity is, and then if they have a low osmolarity, typically they're going to figure out what their volume status is as well. We'll go into more in details on these a little bit later. Okay, so let's say, for instance, we have a hypertonic hyponatremia. Okay, so again, usually this is going to be in the case when you have like kind of excess present osmoles that are floating around. The more common one we mentioned is going to be hyperglycemia, especially with like type 1 or type 2 diabetic patient who's coming in who's not being very well managed on their insulin, things like that. Typically is where you run into this, and you're going to find that the glucose provides a pretty high osmolar shifting fluid over to the ECF, and so this, by causing this extra fluid to shift out of the ICF into the ECF, you typically see that the sodium that's there ends up getting diluted out. So it appears to be a hyponatremia, but the total body amount of sodium is probably going to be relatively normal for the most part. It's just that it tends to be diluted out. And so an actual kind of a handy thing we'll do sometimes for these patients who may have a blood sugar of like 500, 600, 700, what we'll actually do is that for every 100 milligram per deciliter increase in glucose, we know that drops the serum sodium roughly 1.7 milliequivalents per liter. So you can kind of do like a corrected serum sodium to kind of figure out if this is something where I should actually treat this, or if something I can kind of hold off on, right? Because you don't want to have to give extra sodium to someone who doesn't really need it in those cases. I won't quiz you on this specifically, but if you ever work with like nephrology or in the ED, you may run into this calculation. You'll do this every once in a while. Other things we can see this caused by, if you were to give like mannitol or anything else that's contributing osmosis to the blood, this is a big one. We see this in the tox world when we're dealing with like toxic alcohol ingestion. So if you have like methanol, which is windshield washer fluid, or like ethylene glycol and radiator fluid, that's where we end up kind of running into that more commonly. Don't drink radiator fluid, by the way. It's a bad idea. Tastes very sweet. Looks like Gatorade. Don't do it. Don't put it into Gatorade bottles either, because people do that and then kids drink it. It's no good. Anywho, now on the other hand, if you were to have like a hypotonic hyponatremia, we said this is the more common thing you're going to run into, and there's lots of different causes for it, but this is where you're going to identify what the patient's volume status is, whether the euvolemic, hypo, or hypervolemic. And again, the treatment is going to be different based on which of these types we're talking about. And we'll get into the specifics and talk about the different medications, ones we haven't covered before, that can help to manage this. So if you have a hypovolemic, hypotonic hyponatremia, so sodium's low, the osmolarity is low, and they appear to be hypovolemic. This tends to be due to excessive fluid loss, right? So if you have someone who is having pretty excessive diarrhea, vomiting, because again, they have sodium that's going to be in those fluids that's being excreted there. Diuretics is another big one, because we know, especially with like loop diuretics, how do they cause diuresis? They prevent what from being reabsorbed? Sodium, right? And then sodium's in the renal tubule, and that draws water along with it, and then that gets peed out, right? So again, they're losing a lot of sodium. So if you had someone who's abusing diuretics, that could be a case where you could see this sort of stimulation, or this situation here. Because of that, because they're going to be detecting this low osmolarity, or basically you're going to end up having like AVP increase in release. Because of that, because again, it's going to want to try to increase that blood volume, because you are probably going to be hypovolemic based on what we're talking about here. And so what you end up finding is when that AVP gets released, you're stimulating thirst. And so and typically when a patient is thirsty, where are they going to go to drink initially? Water. And how much salt is normally in water? Probably 0, right? Unless they're going to the ocean or something like that. But typically it's going to be 0 for the most part. And so because of that, it tends to make the hypotonicity even worse, because again, they're diluting out whatever sodium is already there. So you can see how that kind of worsens the hyponatremia in those situations there. And typically what you end up finding is that the urine osmolality tends to be high, due to the fact that AVP also tries to help concentrate the urine. Because again, AVP wants us to try to hold on to more fluid, so the urine osmolarity tends to be pretty high. And again, this is another case where urinalysis can be helpful to try to help us determine kind of what's going on with the patient. And so in a lot of cases, you may find that this can be asymptomatic, though. It's a relatively mild sort of thing you can run into, especially with thiazides. And it may be something that happens a little bit more it's more obvious at first, but then the patient kind of adapts to it over time and is really asymptomatic for the most part, right? So again, not going to be an issue usually with thiazides, but say you had a thiazide and a loop diuretic, it could be potential to make this sort of thing worse. Okay, if you had a euvolemic Hypotonic hyponatremia. So again, this is in the case where you'd have a normal amount of extracellular fluid sodium, but you're having an increase in total body water that's occurring here, and the total ECF volume in addition is going to go up along with that. In this case, generally the patient doesn't really manifest a volume overload, even though they tend to be, they don't look edematous, they don't really look like they're hypervolemic, they tend to stay euvolemic in these cases. And this is the most often when we run into SIADH. You guys know what causes SIADH? Yeah, so it can be kind of a central thing, or it could be sort of a thing in the kidneys, essentially. But some of the causes we run into more commonly are going to be things, certain cancers can do this. So we mentioned like small cell lung cancer, pancreatic cancer. We run into, especially like in the surgical ICU, a lot of head trauma ends up trying to think of, coming before SIADH develops here. It's like a head trauma, stroke, meningitis sometimes can cause this to occur. You know, you can also see this in certain pulmonary disease. And then also you can have kind of a primary / psychogenic sort of polydipsia. So we would run into this more commonly from the tox standpoint when we had people who were taking ecstasy. So you guys know another name for ecstasy? MDMA, so it's methylene dioxymethamphetamine. So it's a type of amphetamine, but it works a little bit differently. It's kind of a different flavor than you see with like a typical like crystal meth or something like that. But one of the things it would actually do is it would cause like kind of repetitive actions to be taken by patients, and would also cause them to tend to drink a lot of water because it would end up increasing SIADH or increasing ADH release. And so, and you guys ever seen like, I don't know if, I'm sure no one's ever been to any event like this, but one of the things that is reported that people who are on ecstasy are typically using to try to help prevent their teeth from grinding, because again, it's one of those repetitive things. What are they usually using? Yeah, you usually have like a pacifier, so that's like one of those things with kind of, you know, seems like raver culture and things like that. But it goes to show they do this like really repetitive motions, and one of the things can be actually drinking. So we've had cases where patients will come in with a serum sodium of like in the low 1 teens, like 109, something like that, and they're seizing from it because they were using ecstasy and they were just drinking a ton of water associated with this ADH release and this kind of repetitive action sort of thing that was precipitated by the MDMA. That patient unfortunately died from that, but it's something that's been reported, you know, elsewhere in the literature. But that's where we run into it from more of a tox sort of standpoint there. So there's several causes for drug-induced SIADH, which is why we kind of harp on it here, because again, it's one of those things where if you have a patient maybe coming into the hospital, you're like, well, like, why are they having all these, you know, electrolyte abnormalities now? What's going on here? A lot of times it can actually be drug-induced, and so it's important to recognize that so you can try to eliminate any offending drugs if possible. So some things that can actually increase ADH release tend to be things like nicotine, which obviously where did you find a lot of nicotine? Cigarettes, absolutely. Tricyclic antidepressants have been accused of this before. Vinca alkaloids, remember where we saw those? Oncology, remember those were like vincristine, vinorelbine, vinblastine, right? So those certain opioids have been accused of this, and also haloperidol. So that's one way they can do it. The drugs can actually increase ADH release. You can have certain things that actually would increase the sensitivity to ADH, so whatever is actually being released is actually becoming more sensitive to that. And so things like acetaminophen has been associated with this, carbamazepine, lamotrigine, which where do you see those two? The seizures, or also more commonly bipolar disorder. Remember, carbamazepine and lamotrigine we can use as mood stabilizers potentially. Certain NSAIDs. In some cases, maybe kind of a combination of the two. So you may see something like MDMA, as I mentioned, or ecstasy, ACE inhibitors, SSRI. So again, there's multiple drug-induced causes. If you recognize this, though, one of the important things to do is go back in the med list and kind of look through to see if anything maybe triggering a reaction. Or it could be multifactorial. It could be something like, you know, they have a head injury and they're also on one of these medications that is happening to kind of synergize with that. And then the last group we have here, we'll talk about treatment in a second, is going to be hypervolemic hypotonic hyponatremia. And so this is typically we're going to have the kidneys sodium and water excretion are typically going to be impaired. And so you're going to find these patients are typically volume overloaded. You see this a lot with like CHF patients, cirrhosis patients, patients with nephrotic syndrome, and basically the kidneys aren't really doing their job in order to make sure they can get rid of that excess water. And so that's typically what's causing a lot of that dilution in the hyponatremia there. Okay, so one of the big things you're going to see with hypernatremia is that the presentation can kind of depend on how long standing it's been. You can kind of have more of a chronic, say greater than 48-hour sort of hyponatremia that develops over time, and it can be fairly mild. So if it's, say in the 125 to 134 range, it's definitely low, but generally it tends to be asymptomatic. But when they do manifest symptoms, it tends to be neurologic in a lot of cases. You're going to find that the rapidity, the more rapid of a drop in their serum sodium it was, the more quickly these sort of symptoms will occur here. So remember I told you that story, the hold your wee for a wee story? Remember that lady was drinking a ton of water, was not going to the restroom? Which sort of hyponatremia do you think she had? Probably hypervolemic hypotonic hyponatremia, right? Because she just had that psychogenic sort of polydipsia where she was doing it to herself. It's one of those cases there where, she basically developed very rapid hyponatremia, and these neurosymptoms started to develop here. So early on, you can see sort of nausea and malaise, pretty non-specific. But as it gets worse, you can start to see things like headache, disorientation, lethargy, and then the big thing we worry about is going to be seizures, right? Because again, if you have a patient who's seizing, what's the first drug you think to give them? Things like Ativan, things like benzodiazepines, right? Is this going to really correct this problem? Not necessarily, right? So again, you may get some benefit from it, but not really as much as you need to. Like you need to replace the sodium, and this may be something where you don't have the initial labs to actually look at to see that initially, right? You can get like an ABG or an ISTAT or something, but this may be something that's a bit of a delayed diagnosis, relatively speaking, versus just giving them some benzos and all of a sudden you fix their seizures. But this is a big thing we worry about, especially when you consider seeing things like brainstem herniation. Why do you think this occurs? Why does the cerebral pressure increase? All right, so that's where the water's going, right? Because if I drop my serum sodium really quickly, the osmolarity goes down, and that's going to cause the fluid to want to shift over to where it's more concentrated, and that's going to be into the CNS. So potentially you could see that as well. Again, not super common, but the seizures is one of the big things that we worry about, and what's one of the common kind of presenting symptoms here in like emergency departments. So, like I mentioned, usually laboratory tests, anything below 135 is considered to be hyponatremia, and typically you can get like a plasma osmolality and then also a urine sodium as well that can kind of help you with a diagnosis. You're going to be looking at other stuff as well, maybe TSH, lipids, kidney function, serum glucose, all those things could be helpful in trying to identify this. Now, of course, with cerebral edema, you have to be really careful because the faster this change in serum sodium occurs, the more likely you are to see that cerebral edema. It takes time for the brain to kind of compensate for this, and so again, if it's over a long period of time, say 24, 48 hours, that compensation time has already occurred and it's kind of re-equilibrated. This is also going to be important when you're correcting the serum sodium. You cannot correct it too quickly, especially if the brain's already had time to adapt. Have you guys covered what happens when you correct sodium too quickly? Central pontine myelinolysis, right? So we'll talk about that a little later, but that's no good. If you cause that, it's not good. Don't do that. So anyway, like I mentioned, that low serum osmolality causes an inward shift of fluids to the CNS, and that's where you see that increased cerebral edema. Okay, so as I mentioned, correction of hyponatremia too quickly leads to those consequences there. The water base is going to be rushing out of the CNS cells, it's going to be rushing out, and you're going to see this intracellular fluid sort of contraction that happens there. So they have this acute decrease in brain volume. Now again, if the hyponatremia is very rapid in onset, the brain hasn't had time to compensate, and so you're less likely to run into this. However, if it's been several days and the patient's, the brain's had time to compensate for the hyponatremia, you have to be really careful. And so there's certain values I want you to remember that you don't want to overcorrect in a certain time period, because otherwise you run in the risk of having the central pontine myelinolysis occur here. And basically you have developing osmotic demyelination syndrome, just another term for it. And so again, either of these terms is totally fine to use for the same kind of condition here. And so basically you worry about this quadriparesis developing here, sort of this palsy, is kind of locked-in syndrome, and eventually death can occur usually 1 to 7 days or so after treatment. So definitely be very, very careful with this. Again, the more cerebral agitation that's occurred, the more cautious you have to be in correcting that serum sodium. So typically you want to treat the underlying cause, obviously, of hyponatremia, and then you have to balance the risk of acute hyponatremia versus that risk for developing that osmotic demyelination syndrome. So basically, if you have a patient coming in, their serum sodium, say, is like 112 and they're seizing, you got to fix the seizure first, right? Because that's the immediate thing that's going to kill them. But you don't want to rapidly correct it too fast, otherwise, you have the OPS risk that can develop there as well. So it's kind of a delicate balancing act. We'll talk about some of the ways we kind of evaluate how we manage that in just a few minutes here. Now, typically the rule is if you have a hypovolemic hyponatremia, right, so they're volume depleted already, I don't need to give them really concentrated serum concentrated sodium chloride to fix this. I need to give normal saline, because remember, what's the concentration of sodium in normal saline? 1 54 milliequivalents per liter, right? What's the serum sodium for this patient I'm dealing with? It's probably less than 135 because I'm saying they have hyponatremia. So that 154 is already higher than wherever they're at. You're going to bring them back up just by virtue of giving NS, okay? So again, if you can get away with just giving NS, that's going to be great. So you can just administer that. If they have hypovolemic hyponatremia, because guess what? By giving NS, you're also going to be fixing their volume issue as well, okay? So that's a good thing to remember there. If they have euvolemic, hypervolemic, or hypervolemic hyponatremia, that should be managed with water restriction. And we'll talk about things that can help us to antagonize the effects of ADH or arginine vasopressin. So we'll talk about a drug called meclocycline. Does anyone know what goes in the same family as this drug? If you had to guess based off the name. Tetracycline or doxycycline, right? So again, we're going to run into this. This is actually in the same category as those drugs. We'll talk about that in a little bit. We also have some arginine vasopressin receptor antagonists. We'll talk about briefly. And then also in some cases, you may actually give NS plus a loop diuretic to help get rid of some of that extra fluid. So we'll talk about that a little bit later. And really only want to use concentrated sodium chloride. So again, it's going to be anything greater than 0.9% in order to manage symptoms of really severe hyponatremia. So if they're seizing, that's where I'm going to give things like 3% saline to try to correct that, right? Because that's going to be the fastest way I can correct that, because I'm giving a ton of sodium in a very concentrated volume. Okay, so I mentioned for treatment of acute or a severely symptomatic hypotonic hyponatremia, I can manage it with 3% saline, which is again 513 milliequivalents per liter, or in potentially in some institutions I can utilize normal saline. It just depends on how severe the symptoms are. The more severe they are, the more likely I'm going to be using something like a hypertonic saline there. And again, some institutions even use 23.4% saline. This is like walking around the unit with like a loaded gun basically, because you give this to the wrong patient, serum sodium is going to go up pretty significantly, because it's 4,000 milliequivalents per liter. So again, some places like certain surgical ICUs, they felt very comfortable giving this. This is just what they used. However, I would feel very nervous before administering that. 3% saline is scary enough as it is. So anyway, and again, this is not something you want to keep on the units. Typically, it's something that has to come from the pharmacy, because there's such a risk associated with giving this to the wrong patient. Say for instance, you're just going to the machine where you're getting your fluids and you accidentally pull the 3% instead of the NS, you can kill somebody pretty quickly like that. So anywho, typically, you can shoot for a target of about 120 milliequivalents per liter. They're very unlikely to develop a lot of neurologic symptoms if they're at this level. It's still low, but it's not going to be at the point where they're developing seizures in most cases. And so you can kind of shoot for that. Excuse me. And then again, by comparing the urinary sodium to the corrective fluid you're going to be administering here, you can actually find in some cases that by giving normal saline, you can actually worsen hyponatremia and SIDH. So again, we'll talk about SIDH and how we're going to manage that a little bit later. But just be careful to make sure you're not going to be potentially worsening the patient's case by giving something like normal saline here. Okay. And again, anytime you're worried about volume overload, so if you have a patient in like CHF or cirrhosis, things like that, you can give loop diuretics to kind of help to get rid of that extra fluid. You'll still lose a little bit of salt there, but it's not going to be as much as the fluid you're losing in the process. If that makes sense. Okay, so patients with hypovolemic hypotonic hyponatremia, again, you can utilize normal saline to correct both the hypovolemia and hyponatremia. I've kind of already elucidated why that is the case here. And again, hypervolemic patients tend to be more difficult to treat because their volume is already kind of expanded to begin with. In those cases, that's when I may need something more concentrated like 3% saline, because I can give basically a third of the volume that I have to give of normal saline in order to correct that. And again, loop diuretics can be very useful in helping get rid of the extra fluid. Okay, so how would you determine how much sodium that you can give the patient? How do you determine how much volume you should give them to correct them? And so basically, one standard rule of thumb you want to know is that you don't want to correct any faster than 12 milliequivalents per liter in the first 24 hours. If you correct more than that, you tend to run your risk of having that OPS develop there. So that's a good rule of thumb to remember. Don't correct more than 12 milliequivalents the first 24 hours. Right? Don't correct more than 12 milliequivalents in 24 hours. Bears repeating. Anywho, so basically what you can do, and I'm not going to have you correct this or figure out any of these calculations here directly on the test, but this is kind of what goes into it. And we do this on the unit, or we do this in the emergency department to figure out how quickly we're going to be correcting their sodium based on the volume and the type of fluid that we're giving here. And basically what we're calculating is what we want to see is that change in the serum sodium. Okay, so again, if we're and typically you're shooting for 12, 24-hour period. And so what you can do is you can take the sodium of the IV fluid that we're going to be administering minus the sodium that's in an actual serum, so that's what the actual patient's measuring at currently. We'll divide that by the total body water plus the volume of IV fluids. That makes sense? So basically we're looking at the difference here in the serum sodium between what the fluid I'm giving is, which should be higher than what the patient is at currently. And then we're looking at the total body water plus whatever volume we want to be giving to the patient. So what we do is we typically will try to figure out what total body water is by multiplying out. And typically for guys, it's going to be 0.6 liters per kilogram. And for females, it tends to be 0.5 liters per kilogram. Again, everyone's going to be a little bit different, but that's a good starting point for most patients. So, and again, our goal here is to achieve a sodium of 125 to 130 at the end of the day, right? And so again, this may take a few days depending on how severely hyponatremic they were to begin with, but that's generally where we're going to be shooting for, okay? So let's say, for instance, we had a 66-year-old woman who came to the ER for vertigo and disorientation. She started carbamazepine 10 days ago. Now, do you remember anything about carbamazepine you have to monitor? Serum sodium, right? Because it's one of those drugs that causes SIADH. Remember that? Way back in the neuro section, a long time ago. Anyway, again, the stuff comes up, right? So anyway, she started carbamazepine. She has bipolar disorder. And basically, you find her serum sodium to be 108. It's a pretty scary number. 108 is not good, right? So 135 is the lower end of normal for those patients. But let's say it's 108. So basically, what's our first step? Fix the underlying problem, right? So get rid of the carbamazepine. It's not going to clear the system immediately. However, we can at least stop any further doses from being given. So again, our goal here is to correct no more than 12 milliequivalents in 24 hours. So our goal, our desired serum sodium in 24-hour period should be 120 milliequivalents per liter. Right? That makes sense so far? And she's at 108. We add 12 to that, we get 120. So next question is, well, okay, we want to correct her pretty quick initially. So we said, well, how much 3% sodium chloride can we infuse into this patient in order to correct her issues? So we'd say our change in serum sodium is going to equal 513 milliequivalents per liter, because this is the concentration of sodium in the 3% saline, right? Minus the 108, which is what the patient's at. And then we're going to take her weight times 0.5, because we said the total body water for a female is typically going to be 0.5 liters per kilogram, so we'd have to know how much she weighs. And then we're going to multiply, again, her weight 60 kilograms, we're going to multiply that. And then we'll say, well, how much would a liter of 3% saline actually correct this patient, okay? So again, we're not going to give her a whole liter of 3% saline. We're trying to figure out how much this would actually correct her if we did this, okay? So basically, we would say that a change in serum sodium is going to equal basically 405 divided by 31. So if you multiplied all that out and did all the math, you get basically 405 divided by 31. And you find that you get a 13 milliequivalent per liter change with 1 liter 3% normal saline, or I'm sorry, of sodium chloride, okay? Everyone with me so far? I know it's late on a Friday. You can go back and review this. It'll make more sense when you have after breakfast on Saturday or something, when you have some carbohydrates on the brain. It'll probably be a little bit easier. Anyway, you can set up like an 8 o'clock time so you can kind of like adequately like recreate the situation listening to me early in the morning. I'm just kidding. Anyway, so okay, so we said our desired change is 12 milliequivalents, so we can just do that 12 divided by 13. And so we know that we'd have to give roughly 0.919 liters, or basically 920 mLs of 3% saline over a 24-hour period. Okay, so again, less than a liter of 3% saline would be able to correct her, and we can just basically divide that rate. So if you did 920 divided by 24, you get whatever that rate is as far as how much you would have to get mLs per hour. Okay, that makes sense so far? Let's look at it if we were to use 0.9% sodium chloride instead. Because again, 3% saline is something you don't want to use unless you have to. So especially if she was like very hypervolemic, that'd be something you might want to consider. However, she has an SIADH, so she's probably euvolemic if anything, right? So if we did that math again, we could say, okay, well, let's use 154 instead of that 513 as we did in the last equation here. All the rest of the math is going to be exactly the same. But what you end up finding is that with 1 liter of normal saline, she gets roughly 1.48 milliequivalents of sodium difference in sodium, right? So I infuse 1 liter of sodium chloride into her at normal saline, it's going to be basically 1.5 milliequivalent change. So that means that over a 24-hour period, I have to give 8.1 liters. Okay, anyone divide that by 24? How much is that? Anyone? Anyone? No one's doing the math with me? You get my calculator. Yeah, so 8,100 divided by 24. That's 337.5 mLs per hour for 24 hours. That's a lot of volume, so that's probably going to be too much for her. So you may use something where you may do half of the 3% saline, then you may switch over and use normal saline for the rest. But these are the sort of the sort of math that we're doing to try to figure out, okay, well, how much do we need to give her over a 24-hour period to make sure we don't overcorrect her, right? Because if you correct her too quickly, and again, she had the SIADH develop over 10 days, so that brain's probably had time to really equilibrate. If you correct that too quickly, that's when that OPS, that demyelination syndrome, is going to be more likely. So this is probably a patient that probably more think, okay, well, let's maybe do the 3% saline, give that as an infusion over the 24-hour period, and then we can kind of reassess and then maybe switch over to NS later on. Are you with me? Okay.
Do you guys ever front load that to sort of get her out of the danger zone?
100%. Yeah. So basically what we would do is if we had a patient who came in, so if that patient came in seizing, we saw that 108, which could be likely, right? So if she was already coming in that symptomatic, what we could actually do is give, maybe we'll do like half of that. So maybe we say, okay, what would be 6 mil equivalents? And give that as to her over several boluses over the short period of time until she stops seizing, right? So that way you can, once she is kind of stabilized from that standpoint, she's not done seizing, then you can infuse the rest of it over the rest of that 24-hour period. So that would be a very common thing we would do in a lot of cases. Okay, so anyway, so let's say we had treatment of non-emergent hypovolemic. We said, again, use normal saline if you can, but again, watch for that amount of volume you're going to have to give. 300 mLs an hour for 24 hours is a lot for anyone, especially an older patient who may not have great kidney function to begin with. So that's something you'll have to kind of assess there. Again, you're much less likely to overcorrect with normal saline than you would with 3% saline, so you can always be very careful whenever using that. And the normal saline is good because it helps replenish volume as well if they are hypovolemic potentially. Okay. Now, as far as management of SIDH, so let's say we're also going to be correcting that patient's SIDH once she kind of gets out of the danger zone, maybe when she's up to 120. Typically, again, you want to make sure you're going to be discontinuing under the offending agent. So in that case, we get rid of the carbamazepine. We also want to restrict water for her, right? And again, we know that she has too much ADH floating around. So again, she's going to typically be pretty thirsty, right? So this is something we may have to make sure you're removing, make sure family members know not to give her any water. She's going to be asking for it. They might try to sneak out of their room to go down to the cafeteria. They will do all sorts of things to try to get that fluid because they're really, really thirsty. So anywho, so again, you typically will restrict the water intake to maybe 1 liter to 1.2 liters per day, either oral or IV or combined. And basically at that point, you can also give sodium chloride tablets because again, that's a way to give no volume, but by giving a sodium chloride tablet and a loop diuretic, that will help to increase solute intake and get rid of some extra fluid there. So again, that's another thing we'll do. If we can just get away with just fluid restriction, that is probably going to be the best thing, but sometimes we'll give the salt as well to kind of help them out. Because again, when I give a lot of extra salt through orally, what is that also going to stimulate? More ADH basically, right? So again, that can kind of be kind of fighting yourself a little bit from that standpoint. All right, so again, we have a few drugs that can help us out. So if they were not maybe responding well to the hypo or to the fluid restriction there, we can give some drugs that can actually antagonize the effects of ADH. So dimethylcycline is one. It's actually a tetracycline derivative. And so what this is going to be doing is basically inhibiting tubular AVP activity. So if arginine vasopressin is not working well in the kidneys, what does it actually cause? Because you're getting rid of all those aquaporin channels and the renal tubules. So it causes diabetes insipidus, right? And typically diabetes insipidus is characterized as what? Like massive polyuria, right? So you're going to be seeing a lot of fluid loss. So we're basically trying to induce a diabetes insipidus, a mild one in this patient, to try to counteract all the extra AVP that they're releasing inappropriately. So basically, it takes several days to work, but it's not going to be good for patients who may have compromised fluid intake, not going to be good for patients with liver disease. And again, remember, because this is still a tetracycline, who do you not want to use it in? Pregnant patients and kids less than 8, right? So that would still be contraindication for this regardless. But older patients works totally fine for a lot of them in those cases. And in some cases, watch out for renal functions, can cause some acute kidney injury, but a lot of cases it's good to get them through that initial hump to correct the SIDH, especially once the offending drug is gone, and then they're good to go essentially. In some cases, with it being more of like a head injury or something like that related to trauma, could be a little bit more variable how long it's going to take to resolve on its own. And so you may see a little bit longer courses used for this. But typically, once the drug, if it's drug induced out of the system, then it should correct itself pretty quickly. Okay, we also have a couple of vasopressin receptor antagonists. There's a couple of different vasopressin receptors, but the one we're focusing on here is the V2. So we're going to call these V2 antagonists, or colloquially they're known as the Vaptans. And so basically they're going to be decreasing that water reabsorption in the kidneys. So another name is an aquaretic. And then the two big ones we have here is called conivaptan and tolvaptan. These are mainly going to be used just in the hospital sort of situation. So if maybe they're failing dimethylcycline, we start them up on one of these Vaptans. And so conivaptan itself is IV only, so typically you mainly see it just in the hospital. But tolvaptan, be careful because it is metabolized through 3A4, so you can see some interactions there. And it would be contraindicated for anuric patients in those cases. Again, these drugs, dimethylcycline, the Vaptans, they're not good for rapid correction of serum sodium. So if they're seizing from the fact they're hyponatremic, like really the biggest thing to fix them is going to be what? Give them more sodium, right? So 3% saline, that's typically the thing that's going to fix them. Okay. Again, if they have a non-emergent hypervolemic hypotonic hyponatremia, this is where you basically want to induce a negative water balance here. And so again, correct the underlying problems of a CHF. Maybe they need, like some milrinone, maybe they need some dobutamine, something to try to increase that left ejection fraction. And also, we're going to try to limit their salt and water intake as well for those patients. Again, looking for things that can increase contractility. Things like digoxin can be useful here. Sometimes ACE inhibitors can be good for like an afterload reduction by reducing blood pressure. So sometimes they can be some additional benefit if they weren't already on that to begin with in most cases. You guys okay if I just finished up? Not a break? Okay. Okay. Switching over to hypernatremia. So generally this tends to occur mainly from extrarenal or renal fluid losses. So typically it can be due to excess salt intake. So if you had someone who's maybe doing, I don't know, there were cinnamon challenges, there's been Tide Pod challenges, anyone doing like a salt challenge as of late? If anyone wants to break out as a YouTube star, that may be the next thing, so may consider doing that. Anyway, so you can see it there. You can see if you're using a hypertonic fluids, potentially in patients, excess sodium ingestion. So certainly I remember when I went on my honeymoon, we were in St. Lucia, and they had a breakfast buffet every morning, and I probably ate at least 40 pounds of salted or smoked marlin and tuna over the course of the, I would say like 2 weeks. It was actually like a week though, so unfortunately I was picking out a little bit. And I just remember how much salt I was just losing in out of the urine after we left there. I was just like, why am I peeing so much? And it's like, oh yeah, probably because my sodium was like 160 when I left here. But anywho, a lot of extra salt ingestion could also cause this, but mostly you're going to find this due to renal losses of fluids more than anything. So again, you have to kind of figure out, are they hypovolemic? This could be renally mediated. This could be due to diuretic use in some cases, or it could be related to some post-op diuresis. If they're euvolemic, this is more likely going to be something like a diabetes insipidus, and there's also going to be some drug-induced causes we'll talk about here in just a little bit. Anyone know like the primary drug-induced cause for diabetes insipidus? These are bipolar disorder. Lithium, yeah, lithium is going to be a big cause for this. We see this with some regularity for patients on lithium. Or like a primary kind of polydipsia. And then the hypervolemic tends to be more due to sodium overload. So again, if they were getting, say, salt tablets, or if they're ingesting, say, sodium bicarbonate for whatever reason. In some cases, if you had like maybe too concentrated a tube feeding, so they weren't being diluted enough, that could be one thing. Or like sodium-containing medications. This is less frequent, but it can still occur occasionally. Okay, so I mentioned, water loss commonly occurs to insensible losses. What are those considered to be? Sweat, lungs. Those are the main ones, right? So kind of insensible things that can't really be measured directly, like with your eyes and nose. And so what you're going to find is that typically a lot of hospitalized patients are not given enough free water to really account for this in a lot of cases. And so the other thing you'll see as well is going to be this diabetes insipidus. And there's several varieties. So you can have more of a central diabetes insipidus, where you're actually decreasing the amount of AVP being released. You can have more of a nephrogenic one, where basically there's kind of a decreased response to AVP within the kidneys. So your pituitary could be sending out enough AVP, but really the kidneys are not really responding very well to that. Or if you're having like a really large volume excretion of dilute urine, that could be another way you can end up developing the hypernatremia associated with that as well. That's mainly the big thing you're going to be seeing with that. So some causes for central diabetes insipidus could be things like hypodipsia, so not really having enough fluid intake. Neurosurgery, we actually see this with some regularity. So someone going like head trauma after a car accident or something like that, sometimes we'll see that when they go see the neurosurgeon. CNS malignancy, actually even ethanol ingestion can cause this. So again, remember how I mentioned that usually ethanol will depress ADH release. Remember, so when you break the seal, you have to go to the bathroom all the time, because you're kind of inducing a little bit of a diabetes insipidus when you're drinking ethanol, right? Not that you guys know anything about that, but if you ever experience it, you'll know that it causes a little bit of diabetes insipidus. Anywho, some other nephrogenic causes. Lithium is going to be a big one you're going to run into pretty frequently, but even like the meclocycline, as I mentioned, is that's a reason why we give the drug, is because we want it to cause diabetes insipidus. Our vaptans as well, as we already mentioned, and even things like Amphotericin B. But lithium is probably the most common one you're going to run into in patients who are being kind of, don't really have any other kidney issues to speak of. This might be the thing you'll run into it with. Okay, so typically you're going to find a lot of shifting of water from the ICF over to the extracellular fluid, and that will develop into polyuria eventually. And so typically you're going to find that the symptoms tend to be neurologic in a lot of ways. See a lot of restlessness, irritability, and you can also see seizures here as well, especially when your sodium starts to get up around like the 160s or higher. And again, typically the body can handle more hypernatremia, they can't hyponatremia, so it's less likely to see seizures here, but still a possibility. And again, acute onset, just like hyponatremia, tends to be more symptomatic than more chronic presentations. So our goal here is we'd like to get their serum sodium down to 145. Again, if you have too rapid a correction, very similar to what we're seeing with hyponatremia, if you give the brain time to correct to that new normal of a high serum sodium, you have to give it time to really correct to it getting lowered in those cases. So if it corrected too quickly, that's where you can see cerebral edema versus the hyponatremia where you saw cerebral shrinking, if anything. The other thing is you want to continue sodium restriction, obviously if they're hypernatremic, and then we can do fluid replacement to try to prevent further recurrence. So for hypovolemic hyponatremia, right, so they're fluid depleted but they're hypernatremic, here we can actually just give normal saline, because again, if they're sitting at like say 160, 170s, or it's high 150s, something like that, by giving them normal saline, we can still kind of correct them because we're going to be kind of repleting their volume status, right, and that's going to help to drag the sodium down anyway in those cases. So typically you want to do that until the volume is restored, so they're euvolemic, and then you can actually start them off on something like half normal saline, or potentially if they're a candidate to do something like D5. Typically, I very rarely ever recommend just doing D5 by itself. You usually want to give them a little bit of sodium. So you can do half normal saline. You can even do something like quarter normal saline, which is like 0.22%. But that one's used pretty rare as well. And so typically, another good rule of thumb is to correct at about 10 to 12 milliequivalents per liter per day, very similar to what we saw with the hyponatremia. Okay, so if we have essential diabetes insipidus, so if our brain is not sending out enough AVP, what we can do is actually replace that. And so we have something called DDAVP. And basically, you're going to find that this drug doesn't have a really good oral absorption, so we actually use it as a nasal spray most often. So if you ever see DDAVP being used, usually as a nasal spray, it could either be due to diabetes insipidus, or actually what you can find, you can use it for certain clotting disorders, which I'm not going to get into here, but just know there's some other uses for it than just for diabetes insipidus. But basically, you can adjust your dose to try to get urinary concentrations of sodium kind of back to normal and get your urine volume down to something like maybe only 1.5 to 2 liters per day, and then your serum sodium, try to get it closer to a normal range there typically. Another name for this is desmopressin. If you ever see that, it's another name for DDAVP. You can actually end up, because it is replacing AVP, the patient is not releasing, you can actually see some symptoms of SIDH. You want to make sure you're monitoring and not overcorrecting in those cases, because otherwise you have the kind of the opposite problem that happens there. If you have a nephrogenic diabetes insipidus, this is where typically you want to go ahead and discontinue the causative agent here. So again, if they're on lithium, like try to get them off the lithium, maybe switch them over to something else for that. So what are some other drugs I could use for bipolar disorder than lithium? You could use carbamazepine, but that may actually cause SIDH. What else could I use? Valproic acid is a really good one. A lot of people are using valproic acid. Really don't have any renal issues with that drug. So that's a good option there. And so anyway, if we can, typically try to induce kind of a mild ECF sort of deficit with a thiazide, and then by actually holding salt, you can actually cut down the urine volume. It may seem kind of counterintuitive that we would give a thiazide diuretic, you give any kind of diuretic for someone who's already peeing a bunch because they have diabetes insipidus, but by doing this, you're trying to help to correct the sodium correcting ability of the kidneys, because again, usually you're seeing a pretty dilute urine. By doing that, you can kind of help to reestablish that correction a little bit. And so it does make sense and actually does manage itself for the patients pretty well there. Another one you may see it used occasionally is called indomethacin. Anyone know what type of drug this is? Yeah, it's an NSAID we use occasionally, and this can actually potentiate AVP activity. So if the brain's sending out enough, but the kidneys aren't responding, sometimes that'll help to increase a little bit of that activity there. Okay, and if they have a sodium overload, obviously limit their sodium intake if you can. Say no more smoked fishes for you, my friend. Just enjoy your honeymoon some other way. And then something like loop diuretic can actually help to facilitate better sodium excretion as well. And then using a hypotonic solution like D5 or something like that, or half normal saline can be useful additionally. Okay, so that's it for this section. Any questions? Fantastic. You guys have a wonderful weekend, and I will see you Tuesday.